Good afternoon. Welcome to Plenary Session 3, Advocacy Initiatives in Limb-Girdle Muscular Dystrophies. My name is Sarah Shira Emmons. I am Vice President, Patient Affairs at the Jain Foundation. It is my pleasure to host this important session where the speakers will share information with you that demonstrates how critical advocacy is in achieving our common goals. You're going to learn about some incredible milestones, achievements, and important initiatives that are paving the way towards progress across all the LGMDs. So without further ado, I'd like to introduce Dylan Simon of the Everylife Foundation, who's going to give us an overview of advocacy for rare disease.
Good afternoon. Thank you for having me here today. Again, my name is Dylan Simon. I'm the Director of Policy at the Everylife Foundation for Rare Diseases. And I'm here to answer the simple question of why advocacy matters. So we want to provide kind of a broad avenue in terms of impact of advocacy on the rare disease community and why it can be so important and so fulfilling to really advocate on behalf of your community. So I want to start the conversation around kind of a highlight of the rare disease ecosystem. And so what you can see here is kind of the general role that the patient community is experiencing within the cure to care continuum. And you can see here, I'm not going to go into detail the entire slide, but really at the core of the idea is to really show how many people are involved and how many steps are included within this process to go from a cure to care. And that's only the beginning. So we're starting with the initial idea of like, what does a treatment look like? Then you're starting to bring in some of the academic and universities, bring in the biotech companies, and really start to have that conversation and go through that typically 15-year process of developing an FDA-approved cure. That's only halfway. And then we start getting to the care side. How are we looking at government agencies? What are we doing in terms of payers and manufacturers? And understanding the fact that there's a high cost associated with all this. And the reason I want to talk about this is, again, to really highlight the fact that there are so many aspects that you can advocate for within the entire continuum. And so there's a place for everyone to advocate on how that's impacting their lives and their families' lives. And within the state of rare, it's important to kind of know where we are in the world. And so typically, as I said, you're seeing a 15-year average for a drug to be developed to receive an FDA approval. In addition, a 2019 study showed that the economic impact of rare diseases on the full healthcare system was just under $1 trillion. And so we know there's a high cost, both within direct and indirect costs, but we know that it's impacting both the community and the healthcare system overall. And we know that over 50% of rare diseases have pediatric onset. And so we know there's a way that we can start addressing some of these issues early on in life. But unfortunately, of the over 10,000 rare diseases, only fewer than 5% have an FDA-approved therapy. And so we know there's a lot of work left to be done. And that's just getting again to the cure. I'll talk a little bit later around the idea of access and actually getting to the care aspect. But just in the idea of finding the cure itself, we know there's a lot of work to be done. Which is why we always like to say time is our most precious commodity. We have to work quickly and hard because we know that we cannot waste time in terms of trying to find those cures, trying to ensure better and easier access. And that's where advocacy can really play a role. It's looking at how can you speak up on behalf of your community, your peers, and really highlight here are the challenges that I'm experiencing, and here are ways that we can make it better. And we know there's ways to make it better. And so within the rare disease community, we really look to reshape the landscape through federal advocacy and policy. And when looking at federal advocacy, it's really looking at how can you interact with federal partners. I won't talk today really about state advocacy, but it is an important aspect of the advocacy environment, especially when it comes to access. There is a lot of state work to be done there. But today I'll focus a little more on the federal advocacy side and really looking at the various programs that we utilize, but really at the core is how can we ensure the fact that advocates are both learning about the issues that could impact them, communicating with us about what issues are impacting their lives, and then putting them in front of both federal agencies, congressmen, and their staff, and making sure the fact that they're talking about the issue and what is needed to improve their lives. And so that's where rare disease legislative advocates come in, or RDLA. And so this really serves as an advocacy center, a platform for the rare disease community. A really key part of the Everylife Foundation is making sure the fact that disease communities and disease organizations can speak on the issues that are important to them. As a broad rare disease organization, we advocate for broad rare disease policies. But we also know that there are a lot of individual policies that are important to each individual community. And so we want to ensure the fact that we're providing the resources and tools for individual advocates and patient organizations to advocate for the issues that are important to them, so they feel comfortable going out and telling their story and speaking about what's important to them. And then again, all events and resources are free and available to the full rare disease community because, again, we know the challenges that many organizations face, and we want to make sure that we're being supportive of the full community. And it really gets to the idea of why relationships matter. And so at the federal level, we did this study. There was a study done a few years ago that really showed what actions lead to a positive influence. And so you can see towards the bottom, you have form email messages. That is something that our organization uses, a lot of DC-based policy and advocacy organizations use, and they definitely have an important impact. And you can see there is some influence, and we know that, and it's important to continue to stay in front of these federal officials. But there's a reason that's towards the bottom. You see at the top, the number one in terms of having some influence is in-person visits from constituents. And I also like to point out that the second is contact from constituents, because in this new world where a lot is being done virtually or over email, there's only that 1% difference between in-person visits versus contact from constituents. But this really is to highlight that the most important thing in terms of actually having an influence and bringing positive influence to getting new policy implemented is for offices to hear from their constituents themselves and say, this is my story, and this is why this policy is important to me, and this is how this will make my life better. And more often than not, you're talking to members of Congress. And so here we have the Rare Disease Congressional Caucus, which has just under 150 members in the House and just under 30 members in the Senate. And it's important for it to be a bipartisan, bicameral bill because the Rare Disease Congressional Caucus really ensures the fact that the rare disease community has a permanent voice on Capitol Hill. It ensures the fact that there's a way for staffers and members to stay educated on these issues. We work on rare diseases as a whole. Many other disease-specific organizations focus specifically on their one organization. We are interacting with staff on the Senate side who have to be aware and knowledgeable on the entire healthcare system. And if you're on the House side, you're working with staff and members who have to be knowledgeable on the entire healthcare system, and then a few other areas as well. And so being a resource to them and making sure that they're educated on the issues is being helpful to them. They more often than not want that education, want resources off the Hill where they can go, we know this issue is important, but I need a little more education. Why is this important? How can we be helpful as an office? And so the Congressional Caucus has quarterly briefings to update staff on the important issues and ensuring the fact that they know about the rare disease patients in their district and ensuring the fact that they are educated on the issues that impact the rare community. And that has had a lot of impact. And so we've seen years of progress. So this year is the 40th anniversary of the Orphan Drug Act, which has helped to really increase the amount of FDA-approved treatments within the rare community. Although, as I said earlier, we're still a long way off with fewer than 5% still having an FDA-approved treatment. We also know that 21st Century Cures recently really helped to impact the rare community and implemented some policies that are helping to speed up that rare disease drug development. And so we know that there is progress being made, and we know that those interactions with members and their staff can really help. And again, this idea of building relationships for the long term. So I said this word a few times already, but relationships is really a key part. Staffers are humans just like us, and if the only time a friend of yours came to you was when they needed something, eventually you wouldn't really want to listen to that friend anymore. And so you want to have that relationship with them in terms of how can I be a resource? You have a question about my community and what's impacting me, I'm happy to answer it. If you have a question that I don't have the answer to, that's okay. I'm going to find the answer and get back to you. Staffers are well aware that you are not going to have every answer for every question at the tip of your fingers, and so it's okay to say to them, I don't know, but I'll find out for you. And so you want to be able to build personal relationships so that you can build rare disease champions because they'll continue to understand the importance of the issues And then you're going to start gaining allies. And that's where you're looking at both champions in the bipartisan, as well as both the House and the Senate, who you know when there's an issue that's important, you can go to them and say, here is why, and they're going to say, happy to help. And so this really gets to the idea of the power of advocacy. We know that legislation and policy impacts science and the drug development process. And we know that advocates in the rare community have the power to affect change and as they take on an active role in that process and really influence legislation and policy. And it's important to note again at the bottom, I said it last slide, but legislators want to hear from you. They want to hear from their constituents about the issues that are important to them because you are the expert in your life, and you are the expert in how you are interacting with the healthcare system, how you are interacting with the drug development process, and what changes need to be made to make your life better. And so they want to hear from you. You'll be surprised when we hold our advocacy events, how many of those meetings are with members themselves because they want to take time out of their day to speak to their constituents, to understand what is going on in their lives and how they can help. And so that, again, that gets to who to engage. And so there is a lot of people you can talk to, which is a good thing and can be a daunting thing. But again, at the state level, you're looking at governor and state legislators. At the federal level, you're looking at representatives and senators. In addition, you can look at committees of jurisdiction. Not every committee in House and Senate are going to impact the work that we work on. The Senate Judiciary Committee is not looking at healthcare. But if you're looking at generally, I would say, the 6 committees of jurisdiction, you can reach out to those members and you can reach out to those committees to have those conversations. And you've heard me talk a lot about staff, so you see the tip at the bottom. I've kind of, again, tipped my hand a little bit. Staff are an amazing resource, and so utilize them. I will say it can be a little jarring at times, some of those initial meetings when you realize how young the staff are. That is okay. I promise you that is okay. They are working hard, and they mean well, and they want to do good. So don't be surprised if you get on the phone with a health legislative assistant and they look younger than I do. They're working hard and they want to do good. And so use them as that resource and be there and be a resource for them and help them along that education process so they know why the issues that are important to you should be important to their member. And so just want to move quickly through kind of a sampling of legislative impacts that the rare disease has seen. So in looking at incentivizing rare therapy development, you can see the list here in terms of what has been done in terms of the orphan drug. So you have that tax credit that started initially at 50%, but now it's down to 25%. The orphan product exclusivity has really been an important incentive among the small biotech where you're having those 7 years of market exclusivity. And then as well as the orphan product designation, which allows to get those incentives in place. All of this was done through advocacy efforts by the patient community, saying we need increased drug development. The incentives are not there for the biotech community, and it's not going to be there unless you help us. And going to them and saying, these are the incentives that are needed to help bring more actors into the space and ensure the fact that we're going to see increased drug development. In addition, looking at how we can continue to build on those issues. Again, the Orphan Drug Act was passed 40 years ago, but we don't stop there. We keep pushing. That's a great base, and we build off that. And so you have seen with PDUFA in the last few years is how do we start to bring patient experience data into the FDA decision-making progress, understanding that patients know what they need, know how the clinical trials are impacting their lives, what is the real-world data, what is the real-world evidence, and what is being done to really understand how potential therapies would really impact and benefit or harm the community. And so in the most recent PDUFA cycle, which passed last year, you saw 3 programs really address rare disease specifically. And one of them, looking at the endpoint advancement pilot, has the opportunity to really accelerate the ability to see more and more approvals within the rare space by better identifying endpoints that can be used in the approval process. Specifically then within the muscular dystrophy space, the MD Care Act of 2014 was really beneficial to the community as a whole to really help to move some of the work being done in the space forward, and has been done a lot of work as well within the patient-focused drug development space. And so here's some of the policy we're looking at today. So the U.S. healthcare system is really grappling with how to incentivize development as well as measure meaningful change and assess value. So you can see that headline, the new treatment could save the lives of babies, but it costs $2.1 million. That is a sticker shock, and that was for spinal muscular atrophy, or SMA. And that is generating a lot of conversation on how do we assess value? What are we looking at to properly identify how to price drugs? What is good value? How do you go about that process? And there's a lot of conversations around, should we change how we look at paying for drugs across the healthcare system? This really gets into the access space that I talked a little bit about earlier. So really ensuring the fact that we're having these conversations, and they'll continue to occur because gene therapies or cell and gene therapies are going to come onto the market more and more often as we move forward. And that will really change how we look at access and value in the space. In addition, the use of patient experience data when informing FDA approval decisions. We have made a lot of progress in this space, but there is more to be done, really understanding the impact of disease and treatment of symptoms, as well as patient perspectives about potential and current treatments. So really ensuring the fact that this data is being included in the process, and there's legislation that has been looking at ensuring the fact that those perspectives are included in a more formal way, because at the end of the day, there are multiple steps along the drug development process, but the only actor who is from beginning to end is the patient, is the advocacy community who says, this is how it's been impacting my life. When we were at the research lab at Johns Hopkins to when we're at our local hospital trying to get access to that new treatment, the patient community is the one who's been there the entire time. And so it's their opinion, it's their perspective that needs to be heard in this process. And this is, again, my last slide, where it really looks at the idea of the patient expert roles across the continuum. So again, I've talked about this a few different times, but as you can see here, there's a lot of different places within the process where you can advocate, whether it's during the discovery period to ensure the fact that there's more academic research being done to support the development of a therapy, whether it's in the actual clinical trial period to ensure the fact that you're having increased access to trials, more diverse trials to ensure the fact that we have a true understanding of the data. And then we get to access. How do we ensure the fact that you actually, once it's on the market, that the community actually has access to that treatment? And so I'll skip this slide real quick. ROI, again, this is our personal why at the Everylife Foundation, but I want to use this slide to really encourage you to determine your why. Why do you want to advocate? Why do you want to get involved in the advocacy process on behalf of your family and your community as a whole? And so once you work on that why and understand that why, advocacy really becomes such a great experience, and you really learn to love the idea of speaking up on behalf of yourself, your family, and the community as a whole. So thank you so much, and I'll pass it off to Paul.
I'm seeing a hand raised in the back. Oh, there we go. Okay. Good afternoon, everybody. I'm Paul Melmeyer. I'm the Vice President of Public Policy and Advocacy at the Muscular Dystrophy Association. Very grateful to be in front of you all today. Very grateful to those who organized this conference. It looks like it's going splendidly so far. Also very grateful to Melissa Grove. I don't know if she's in here, but she gave a better pitch to our advocacy work. There you are. Better pitch to our advocacy work than I could just a couple hours ago. Melissa's one of our fantastic advocates who have joined us on a number of initiatives. So thank you, Melissa. Okay. So today I want to kind of build off of where Dylan started with, which is the importance of advocacy, the importance of using our voice to try to bring beneficial impacts for, in our case, of course, the broader neuromuscular disease community, but really, in Dylan's case, of course, the whole rare disease community, or for this room, those with limb-girdle muscular dystrophy. Now, of course, you know the Muscular Dystrophy Association. I don't think I need to give much background on us. 70 years old, $2 billion of research, 150 care centers, educational programs, advocacy, yada, yada, yada. You know all this stuff. So I think I'll just quickly move on from here to focus a little bit more on our collective advocacy together. So I first want to start just, again, kind of building on what Dylan was saying, on just the immense power that the community can have when we really join our voices together, advocating for change, whether that's here in Washington, D.C., whether that's at the state governmental level, even the local governmental level for that matter. When we all join together, when our collective voices join as one, we are so much more impactful in bringing change to those we serve, in my case, or of course, to those we love, or to ourselves in many of your cases. And so from there, I'm going to take a couple examples from our work together on Capitol Hill, our work together in regulatory agencies, and even just kind of zooming out from there, just even coming together and sharing priorities, discussing new opportunities can have such impacts. And then I'll close with, hopefully by the end of all of that, you want to join us, and I'll tell you how you can. Okay, so the power of the community coming together really just can't be understated. It is so immensely powerful when voices join together, because when we do, especially within rare diseases, we of course increase our numbers from maybe just a handful of folks with an ultra-rare disease to folks with limb-girdle muscular dystrophy more generally, or neuromuscular diseases more generally, rare diseases more generally than that for that matter. And so we go from just a handful of folks asking for a change from a congressperson or from a policymaker at a regulatory agency to hundreds or maybe even thousands of folks coming to these decision makers and asking for them to make that change. And so that expands our reach, of course. We're able to reach more lawmakers, we're able to reach more policymakers. And we're also we're better able to reach consensus, because the more folks we have in the room talking about what do we want drug development to look like, what do we want clinical trials to look like, or an insurance policy for coverage of our specialists, or an accessible experience in air travel. The more folks in that conversation and then delivering that message, the policymakers, the more it's going to be the consensus of the entire community, and the less likely it is to be the consensus perhaps of just a small part of the community. We, in that way, also present a united front. And in bringing everybody together, there's probably no one who's going to be opposing our requests to policymakers, because everyone's saying the same thing, and that makes it easy on the policymakers, trust me. And then we are all the more emphatic in our priorities if we are all saying the same thing, if we're all coming together asking for the same thing, rather than many different things or only a handful of us in our advocacy. So if we're all together, how does this actually make an impact? What are some examples of ways in which we are joining together today, or this week, or this month, this year, to actually create impactful change for our community? Of course, as Dylan was saying, meeting with lawmakers is one of the most important ways of doing so. Sharing our personal stories. We have countless examples of times in which the personal story of someone living with limb-girdle muscular dystrophy, or Duchenne muscular dystrophy, or spinal muscular atrophy, or any of the neuromuscular diseases in the communities that we serve, those stories having impacts on Capitol Hill, having impacts up in regulatory agencies. And I'll give a couple examples of those that have already happened this year or within the last couple of years. For the organizations in the room, signing coalition letters. You see an example on the right of your screen of a letter that we joined with other neuromuscular advocacy organizations on sending to Capitol Hill, asking for clinical trial reforms that actually did pass into law and are being implemented by the FDA right now. This was actually about this time last year when we joined together to send this letter, and I'll come back to this in a moment on just an example of how our organizations have worked together. Just simply signing petitions or reaching out to local media with experiences or other ways to kind of evangelize, but also to collect our voices in ways to have impacts. And then just bringing folks into, under the tent, if you will, bringing folks into the mission. Like-minded individuals who might not be involved right now. They might not know about opportunities to be more involved. But if we're all working together to try to bring more folks into the effort, then that can be incredibly impactful as well. So I want to start with a few examples on Capitol Hill. Now, really with the Muscular Dystrophy Association, we kind of focus on three overarching areas within our policy and advocacy, and you can see those up here on the screen. We seek to increase access to care. That could be medical devices, approved therapies, specialists, home and community-based care, quality health insurance. Really, if it's going to benefit our community's health, we want to increase access to it, and that's kind of what we focus on within this portfolio. We also seek to accelerate therapeutic development, just try to get more and better therapies to the neuromuscular disease community more generally. And of course, recent examples of that have been around ensuring that the incentives are strong for development within neuromuscular rare diseases, and that the research is still occurring, and from there, that the standards and structures of clinical research and clinical trials that then make in front of the FDA are occurring as they should, and FDA's regulatory approach is as it should be as well. And then our third policy area is we call empowerment independence, but it's really just breaking down the societal barriers we still see in front of those with neuromuscular disabilities. And that includes accessible air travel. I'm sure many of you flew here for this conference, and perhaps you personally experienced the inaccessibility and the indignity and sometimes the dehumanizing experience of air travel while living with a disability. We also seek to end discrimination against those with disabilities, increase economic independence and security, and then finally access to educational, also employment opportunities. So just a handful of some recent examples of working together where collaboration really has made a difference, or we're in the process of trying to make a difference. Within our Access to Care portfolio, I first turned towards access to genetic medicine. And this includes access to genetic counselors, access to specialists, the geneticists, and all the allied professionals who know limb-girdle muscular dystrophy or know that neuromuscular disease. And then if available, and of course within limb-girdle right now, there is no gene therapy that is approved, knock on wood, hopefully in the next couple of years there will be, but also available to target the access to targeted treatments, including gene therapies, and of course in other neuromuscular diseases such as SMA as well as Duchenne muscular dystrophy, there are gene therapies currently on the market. But there are so many barriers in front of our community actually accessing these services. Perhaps it's the payment schemes that these professionals aren't paid nearly well enough, so there aren't enough of them, and so there's a shortage. You have to wait a while to get that appointment. Or perhaps the insurance that is supposed to cover these aren't particularly well covering these specialists that of course are medically necessary, but for one reason or the other, the insurance is deciding not to provide that coverage. So you can see over on the right side of the screen, we joined with a number of organizations, actually several years ago now, in advocating for a bill that tries to address this. And actually right now we're advocating for the same bill, the Access to Genetic Counseling Services Act, to try to get genetic counselors actually covered by the Medicare program, because right now they literally cannot be paid by Medicare, which is nonsensical when we're trying to fix it. Over within the FDA side of things, we also seek to come together to try to change FDA's approach to neuromuscular diseases more generally, because something that might be happening within ALS might also be affecting what's happening in SMA, which might be affecting in Friedreich ataxia and limb-girdle and Charcot-Marie-Tooth, and the list goes on from there. Because oftentimes those at the FDA might have kind of the same approach and ideology to how clinical trials should be structured within these diseases, how they should be using expedited approval pathways or not using expedited approval pathways. And so consequently, the community kind of within the neuromuscular disease community by and large faces some of the same challenges of having to endure placebos within clinical trials, endpoints that don't really actually match the experience of living with a neuromuscular disease. It doesn't really measure what's important to someone living with limb-girdle muscular dystrophy. Underutilization of some of the more flexible methods that FDA actually has at their disposal to get therapies through the process more quickly. And then once they're at that end stage of actually reviewing the therapy, being rather inflexible as they're looking at the evidence. So this is something that actually unites the entire neuromuscular disease community, and frankly, rare disease community more broadly. But if we just look at the neuromuscular disease community in particular, we were able to join with many organizations back in the summer of 2021, asking for more flexible approaches, more innovative approaches at the FDA through a vehicle called the Act for ALS, which, while focusing somewhat on ALS, actually is impactful to everybody with a neuromuscular or neurodegenerative disease. And that did pass in the December of 2021, and we're already seeing some of those effects actually taking place at the FDA. Finally, and I want to pause just for an extra minute perhaps on this, because this has been our focus for this year, as Melissa said just a little while ago, and that's accessible air travel. This year we have one of the best opportunities to really reform air travel and make it more accessible, and that's because up on Capitol Hill, they have been working on the law that needs to be reauthorized every 5 years. It reauthorizes the Federal Aviation Act, and it really kind of governs everything about commercial air travel. And so consequently, this is our opportunity to actually make a difference in reforming air travel to make it more accessible. And so we've been kind of throwing everything at the wall, if you will, on this one. We had a Hill Day back in May of this year, in which we met with lawmakers, and you see Madison Lawson, one of our community members, meeting with Senator Josh Hawley here, as well as several other of our advocates. We've had messages going up to Capitol Hill, and actually to this moment we're sitting in right now, we've been very successful. Now, nothing's actually passed Congress as of yet, but we're very excited because within the proposal that they are this close to passing, there's actually a pathway to allow individuals who are wheelchair users to stay in their wheelchairs while flying, no longer folks who are wheelchair users would have to transfer from the wheelchair to the aisle chair, from the aisle chair to the plane seat, and then back, and all the things that can go wrong in that process. And of course, that also would prevent the wheelchairs from being damaged when being loaded into the cargo hold, which we all know happens far too often. Tens of thousands of wheelchairs damaged in that way. So the proposal up in Congress right now would actually eventually allow folks to actually fly in their wheelchairs, just as a wheelchair user can stay in their wheelchair on a bus or on a train or on other forms of public transportation. And in the meantime, while that pathway is occurring, there'd be much more robust training for baggage handlers who actually load wheelchairs into airplanes, or for those who are assisting with seat transfers. So no longer folks would have to be potentially injured by inexperienced and untrained folks actually lifting an individual with a disability and conducting that seat transfer. Within these bills are stronger disability standards, evacuation standards would be updated for those with disabilities, and much more. We had 15 proposals we gave to the transportation committees, and they actually included 12 or 13 of them, which is really remarkable. But the reason that happened wasn't really because of us. The reason that happened was because over the course of the last 6 months, over 10,000 individuals have sent letters to Congress asking for these very things to be included. And that was after our Hill Day had already occurred. So it wasn't our voice necessarily that was accomplishing that. It was all of your voices telling Congress we need to make air travel more accessible, which has gotten us to this point. Now, I said that the bill hasn't passed yet. That's true. And that's because there are debates on some other policy areas that have nothing to do with accessibility. But the bill did pass the House. It was 400 to 20, incredibly bipartisan. Over on the Senate side, they're still trying to figure out their stuff over there. But, hopefully within this next month or so, we're going to actually see these bills pass, and we're going to actually have some of the most impactful changes to accessible air travel occur since the mid-'80s, frankly. So those are some examples of coming together on legislative advocacy, but just to spend a couple of minutes on regulatory advocacy, it can be incredibly impactful talking to the regulators, the administrators, those in the deep state or the swamp, as some call them, because they might have a very tiny office somewhere way up in Maryland or over in Virginia or wherever they happen to be, but every day they're making incredibly impactful decisions for our community. And so just thinking about those at the FDA or those at the Center for Medicare and Medicaid Services, and Melissa gave a great example of this earlier, where it was only within the last handful of months CMS decided to actually cover seat elevation systems for those with disabilities, for those who are wheelchair users within the Medicare program. It's a very small office who made that change, but it's an example of a real substantial impact our community can have when advocating to a regulatory agency. Same goes for some of these other agencies you see on the screen here. The Office of Aviation Consumer Protection, that's the office that tries to make air travel more accessible through administrative or regulatory avenues. And it was they who put out a rule just a couple months ago that said that lavatories have to be accessible on airplanes within the next handful of years. Now, actually, I like to tell the story. Within their proposed rule, they said, we're going to give airlines 20 years to comply with this. 20 years, that's a long amount of time. So we wrote into them and said, okay, we understand there has to be some implementation timeline, but 20 years is ridiculous. Let's cut that in half. Let's say 10. So we also encouraged advocates to say the same thing. And actually, of the 340 letters that the U.S. Department of Transportation got, over 80% of them came from the neuromuscular disease community, came from us advocating together. Those letters said, make that timeline 10 years, cut that in half. So it was just a couple months ago that they finalized the rule, and guess what? A 10-year implementation timeline. They listened to us, they listened to you. And that's because when we join our voices together on regulatory advocacy of this kind, we can make such an impact. Now, of course, perhaps some of the best example of this, one of the best examples of this happened within this very community, LGMD ICD-10 codes, who I'm sure many of you have heard about at this point, the progress that we were able to make over the last couple of years of actually obtaining ICD-10 codes. And those are the billing codes that after you see a clinician, they put within the record to then be reimbursed for their services. And you might think, well, why does that matter all that much? Well, it matters because, for one, previously the code was other muscular dystrophy for everyone within this room. Talk about a generic code that you don't really know what that means. But also these codes have such a big impact on coverage and reimbursement, on disease research and surveillance, because now we're going to be able to better understand progression of disease, where folks with LGMD live, and also it's going to assist with clinical trial enrollment. So we were able to join with the other organizations in the LGMD space advocating for ICD-10 codes for the LGMDs. And we got them. We didn't get all of them. We didn't get 30-some codes, unfortunately. Trust me, we asked. We asked the committee, can we have an individual code for every single LGMD? And they said, no, you cannot do that. But what we can do is perhaps focus on the more prevalent and those that have some therapies actually in the clinic right now. And so these are the codes that we were able to obtain, and they actually have been active for just over a year at this point. So as you see your specialist in the upcoming months, hopefully they are using one of these codes in front of you here, and everybody with the limb-girdle muscular dystrophy is included in one of these codes. So thankfully no one should be other muscular dystrophy any longer. But to the clinicians in the room, if you're not already using these codes, please start and encourage your coders to use them, because now that they're on the books, we actually have to actually use them. And this happened because we all joined together: MDA, Jain Foundation, Speak Foundation, Cure Calpain 3. You know, the list goes on of all the LGMD groups coming together, working with the clinicians in the space to actually get these LGMD codes on the books. And also, I should give a shout out to you all, because there was a petition of over 700 folks within the LGMD community that also was submitted to the committee deciding this. And there's no doubt that everybody joining together, not just the organizations, but the community as well, had an impact. Okay, so just to close on a few notes, those are some of the impacts we've had coming together, but even just congregating and talking about what we prioritize within policy and advocacy is important. And we're proud to convene what's called the Neuromuscular Advocacy Collaborative. We meet once a year in person at the MDA conference in March, but we also have collaborated on many other letters and efforts, and a lot of those letters you saw with all those logos on them, that's coming from the Neuromuscular Advocacy Collaborative. And that's where we also gather and say what's important to each of our neuromuscular disease community, what is really kind of keeping us up at night. Sometimes it's access to specialists and making sure referral networks are in place. Sometimes it's accessible air travel. Sometimes it's clinical trial structures. But when we come together and actually convene on these things, we're able to better prioritize and know that we're better serving our neuromuscular disease and limb-girdle communities. And these are some of the organizations that are present within that effort. And it's not exhaustive. We've actually had more folks join since this slide was put together. But as you can see, it really is a community-wide effort. So that's how the organizations can join. But how can you all join us? Because some of you might actually be hearing about advocacy and your opportunities to join us for the very first time. Well, right here on the screen, there's a QR code you can scan if you'd like. You can text MDA USA to 50457. Or if you just want to email us, and it's our team who answers this inbox here, advocacy@mdausa.org. All ways for you to sign up and join us. Because again, it's your voice that are making impacts on Capitol Hill, on accessible air travel, on access to specialists. It's your voice making impacts at the Center for Medicare and Medicaid Services and accessible air travel efforts in the Department of Transportation at the FDA. We have 5 different opportunities available right now for you to send letters to your congresspersons on a lot of these things. So please do join us, because without your voice, without all of our voices together, we're not nearly as impactful as a single voice asking for these things. I think I have Q&A here, but I don't think we're doing that yet. So I'm just going to move right along, invite Sarah back up. Thank you all.
Thank you, Paul, for that great talk and for your leadership with these collaborations. So next up, we have Glen Nuckolls of the NIH coming to talk with you about Muscular Dystrophy Coordinating Committee and NIH-supported research.
Thanks, Sarah, and I'd like to thank the Speak Foundation for inviting me to come and participate in this meeting. It's really a pleasure for me to be here. So I'm Glen Nuckolls. I'm a program director in the Division of Neuroscience at the National Institute of Neurological Disorders and Stroke, and I'm also executive secretary. It's also called designated federal official of the Interagency Muscular Dystrophy Coordinating Committee. So I'll start my presentation with a quote from Ronald Reagan. He said, "The 9 most terrifying words in the English language are, 'I'm from the government and I'm here to help.'" So hopefully by the end of my presentation, I can convince you that maybe those words should not be so frightening. So the outline of my talk is, first, I'd like to tell you some about how NIH works, what we do, and then I'll briefly describe NIH support for muscular dystrophy research and give you some examples of currently active NIH grants on limb-girdle muscular dystrophy, and then I'll tell you about this coordination among NIH and other federal agencies and patient advocacy groups through the Muscular Dystrophy Coordinating Committee. So NIH is actually 27 different institutes and centers, each with kind of a different disease focus and methodology. We're a total of about $43 billion, but most of those funds go to research grants and contracts to researchers at universities or other research institutions across the United States and in some foreign countries. We do have a nice-sized campus up in Bethesda, Maryland, just up the red line here. Mainly that's for the intramural program, where there are researchers that do research on campus and administrative activities. So there's 4 main institutes that are involved in supporting muscular dystrophy research. My institute, NINDS, as well as National Institute of Arthritis and Musculoskeletal and Skin Diseases, the Child Health and Human Development, and then the National Heart, Lung, and Blood Institute. So this slide shows a pie chart of the $78 million in support for research, grants, and contracts in muscular dystrophy that NIH funded in 2022, which is the last year that we have numbers for it. So you can see that quite a majority of those funds go for what we call research project grants, and those are grants that are initiated by researchers at universities, and they decide what to work on, and I'll tell you more about how they get their grants. The pink up at the top is the Wellstone Centers. So this is a Centers of Excellence program in the muscular dystrophies. We have 6 Wellstone Centers, and 2 of them involve studies with LGMD patients. You've heard about Kevin Campbell's Wellstone Center at the University of Iowa, and they study dystroglycanopathies, and then Lee Sweeney's center at the University of Florida, and they do MRI biomarkers on some Duchenne and limb-girdle patients. We also support training and career development grants, really to kind of support the next generation of muscular dystrophy researchers, small business grants, and intramural research. And this morning you heard from Sandra from Karsten Bonneman's lab, and Pam, who used to be with Karsten Bonneman in the intramural program, and so they have quite a bit of funding, and other labs have funding from NIH to do really important research there. On the right side is a list of subtypes of muscular dystrophies, and each of these has an official code that's done automatically for those subtypes of muscular dystrophy. That we have a total of 315 different codes all across the thousands of conditions at NIH. And this allows us to very consistently from year to year indicate what the level of funding is. I'm sorry, there is not a limb-girdle muscular dystrophy code, so I can't say exactly how much that level of funding for limb-girdle would be. Later in my talk, I will show you a way that you can go download a list of all the grants in the muscular dystrophies, and then see which ones you're most interested in. But I show this really to make the point that NIH does not start the year with a decision about how much funding we want to put into a particular muscular dystrophy or other condition. The vast majority of our funding is done through a competitive process across all of the disease areas that we focus on, and it works through a peer review. So this is a diagram kind of showing you how this peer review system works. So again, research institutions, faculty members, other researchers, they decide what they want to work on, they develop a grant application, they send it to the NIH. NIH organizes a review panel that's made up of other researchers from the community in the same or related areas of research, and they conduct an anonymized review of the quality of those applications. And then it's a competition so that only the best applications from each of the different review panels is considered for funding. So then at NIH, we develop funding plans, and then we have another group of outside people. This is our advisory council that includes prominent researchers, some other feds, and also patient advocacy members or on our advisory council. And they review our funding plans and make recommendations to the institute director, and then based on the level of funding that we've gotten from Congress that year, we'll make awards, grants to the research institutions to support those research projects or training or infrastructure or whatever the application was for. And then we monitor, we provide oversight of those grants. And at the end of 5 years or 2 years to 5 years of grants, then those investigators put in a new application to try to renew that or go in a new direction. So it really is a competition of the best quality of grant applications across any of the fields. And so there's some variation in how much each area gets funded from year to year. So in this slide, I'd like to kind of introduce the concept of a pyramid with basic research down at the bottom going up through health outcomes research. So basic research answers the questions of, can we understand the biology? And then, and that can be done studying patients, studying cells, studying molecules, genes, whatever. And oftentimes with that knowledge of basic research, you can come up with possible ways to treat a condition. And then those strategies, candidate therapeutics, they've got to be tested in animal models to make sure that they're safe and have positive effects. And that's what we call preclinical translational research. And if you've been successful in safety and efficacy in mice or other animal models, then it may be ready to do a clinical trial looking for safety and efficacy in a select group of people. And then, if the clinical trial is successful and the drug or product gets marketed, then you really want to know, is this working for patients in the real world? And that's health outcomes research. So NIH, really, we concentrate our funding at the base of that pyramid in the basic research and preclinical translational research. And other funding groups, such as other government agencies and industry and patient organizations, they also pick kind of the areas that work best for them. And it's really a synergistic effect of all of the funders working together that kind of keeps this going. I'll point out that I draw the pyramid this way with basic research at the base as the foundation, but if you look at the costs of individual projects, the pyramid would be flipped over with basic research projects are very inexpensive and clinical trials are horrendously expensive. So that also affects kind of decisions. So this slide lists some examples of currently active limb-girdle muscular dystrophy research grants, and some of these grants, like one on developing a skeletal muscle tissue model for LGMD 2B, and one on understanding mechanisms of role of cell membrane repair and Meishi myopathy. So these really fit into that base of the pyramid, the basic research. And then I think tomorrow you'll be hearing from Drew Finley on allele-specific knockdown strategies for LGMD D1. We also fund Melissa Spencer for developing gene therapy vectors for limb-girdle. So this is the preclinical translation stage. And then we're not currently funding any clinical trials in limb-girdle, but we do fund this study to Nick Johnson on trial readiness, which is run through the GRASP network. And he talked about some of those studies this morning. So this is validating clinical outcome measures and biomarkers. And we also fund Stefan Zuckner and Chris Weil had told you this morning about the curation panels for validating genetic information of limb-girdle muscular dystrophies for the purpose of researchers and also clinical care. So if you want to look more about exactly what we're funding in areas that interest you, we have a public website called report.nih.gov. And within categorical spending, you can find all of the muscular dystrophy grants, or you can click on the tab that says Reporter and use it to identify researchers in the area where you live or particular topics or really whatever you're interested in. So for the rest of my talk, I'd like to talk about coordination of efforts between NIH and other organizations. And a lot of what we're doing in this area is because of the MD CARE Act, the Paul Wellstone Muscular Dystrophy Community Assistance Research and Education Act that Paul had mentioned earlier, that directed NIH to expand and intensify research, authorize the creation of those Wellstone centers that I told you about, and also led to the creation of the Muscular Dystrophy Coordinating Committee. And Paul Wellstone was a champion for muscular dystrophy research. So the Muscular Dystrophy Coordinating Committee is not just at NIH, but involves a number of other federal agencies like the FDA, CDC, CMS, Social Security, and so forth. And we have quite a number of members that are patient advocacy group representatives. Actually, one of our members, Denise Myler, she represents the Idaho Independent Living Board and the Idaho Caregivers Alliance. She's a person living with limb-girdle muscular dystrophy. So the meetings are chaired by Dr. Bianchi, who's the director of NICHD, and we meet twice a year, either in person or by hybrid. We've been just doing Zoom for a while, and talk about things that are interest to stakeholders in muscular dystrophy research, but also patient care and access to services. We have a website where you can find out more about this committee, and also there are all of our meetings are broadcast live and video archived, and there's links to our previous meetings there. So the kind of major product of the Muscular Dystrophy Coordinating Committee has been what we call the Action Plan for the Muscular Dystrophies. It was first published in 2005 and then last renewed in 2015. And so one of the things we're doing now is preparing for a renewal of the Action Plan. And some of the guiding principles in the Action Plan. So the Action Plan is a document that represents current views on strategies for advancing research, accelerating progress towards timely diagnosis, effective treatments, and then also enhancing health, quality of life, access to care and services for individuals living with muscular dystrophies. And we in our renewal process, we really want to incorporate the perspective of all stakeholders. So we're developing some working groups on topics, subtopics within the action plan. And we've already gotten nominations of people with lived experience, patients and advocates that can serve on those working groups. We'll hear from researchers both in academia and in industry and other federal agencies. And we're really going to encourage the working groups to identify a total of maybe 15 or 20 really priority objectives across all forms of muscular dystrophy. So this is the proposed outline for the renewed action plan. So we're currently developing working groups on mechanisms of disease, preclinical therapy development, clinical studies, and you see how that's really matching that pyramid we were talking about, but also enhancing health, quality of life, and access to care and services. And then with each of the working groups, we'll encourage them to talk about opportunities for collaboration and partnership. So by about this time next year, we hope to have had meetings of the working groups, and we'll have a draft action plan that we will post publicly and solicit public comment. So that's really an opportunity for everyone in this room to consider it and tell us what you think about it and things that we should change, and then we'll incorporate those suggestions in a revision and take it back for potential approval of the MDCC in early 2025. And that's really intended to be a 10-year plan. So our next meeting of the Muscular Dystrophy Coordinating Committee will be on December 8th. This is kind of a draft agenda for it. We'll talk about recent workshops and conferences, We've invited MDA and Parent Project to talk about the strategic plans that they've developed and ways to incorporate those into the renewal of the action plan. And then we'll have a couple of talks about recent happenings in the Duchenne field. So an update on newborn screening from Nikki Armstrong at Parent Project Muscular Dystrophy. Bill Rooney is going to describe a computer model of data from Duchenne that allows for clinical trial simulation. It's really designed to help facilitate the planning of clinical trials. And then Ramona Belfour-Oshan, who's here at the meeting, will be talking about the Duchenne Regulatory Science Consortium and the Critical Path Institute. And this meeting is a bit focused on Duchenne. We try to cover each of the different dystrophies, and one of the goals is really for other dystrophy areas to learn stories of success from either of any of the other muscular dystrophies, to kind of lift all boats and accelerate progress. So that meeting will be broadcast live, and sorry, we just opened a free registration site, but I didn't get that until yesterday or the day before, so it didn't end up on my slide. But you can just, 9 o'clock Eastern on December 8th, you can go to videocast.nih.gov and watch the meeting. Or if you're further interested, please contact me. And so just in conclusion, I think we at NIH, we work to fund grants and to foster innovation, to accelerate understanding of muscular dystrophies and development of new treatment strategies. We coordinate with other federal agencies and with patients and patient advocacy groups to prioritize potential strategies to accelerate not only research, but also strategies to enhance health, improve quality of life, and provide access to care and services. So, and that's for people with limb-girdle muscular dystrophies or any form of muscular dystrophy. So I hope I've convinced you that maybe Ronald Reagan's 9 words are not so scary. Thank you.
Thank you so much, Glenn. It's really great to have you with us and to see all that is being supported by the NIH. That's great. So to close our session, we have Jen Levy, who leads the Coalition to Cure Calpain 3, and Brad Williams of the Jain Foundation to go over community interactions with the FDA and give you an update on what's been happening and what's coming up.
Okay, so I'm doing the first part. Thank you, Sarah. So I'm going to talk and then Jen will take over for me in the middle of the talk about some of the recent interactions that we've had among the LGMD community, as sort of a consortium of the LGMD advocacy organizations with the FDA. Okay, so what are we trying to accomplish here? First, let the people at the FDA know about limb-girdle muscular dystrophies. By the time they have to make regulatory decisions having to do with drug development, we want them to have a good understanding of the disease, and what it's like, knowing that LGMDs are, many diseases, and they vary somewhat, although there's a lot of similarities too, and to share our experiences as patients. What is it like living with LGMD? And what are our opinions on potential therapies? And also, to make the point, the FDA, to approve a drug, they have to conclude that it's safe and effective for treating some medical condition. but both of these are kind of judgment calls, and it's been recognized that patients' opinions on what is effective enough and what is safe enough should be part of the conversation. So, we want the FDA to give us drugs that are safe, that are effective, and also give them to us soon. So, so some of the things, what is living with the disease like? Well, and as a general topic, they want to say, well, what are the current treatments and what are the limitations of current treatments? So that's a very easy one to answer for LGMDs. There are no current treatments. We're waiting on one. And what benefit of a treatment would patients consider meaningful? And that, really is best coming from the patients themselves speaking about their experiences living with the disease. I think a lot of people get the idea that you really want to be able to walk again, or you want a complete cure. That would be the only meaningful treatment. And I will say that in interactions with the FDA, both in the LGMD community and in other communities, no, just stop progression. That would be absolutely wonderful. If you can make me better, fine, but stopping progression is meaningful. And what is our perception of risk? How safe do we need a treatment to be, for us to consider taking it? Now, no one can speak for the entire community. For that reason, we have a bunch of patients each giving their opinion on that, for the FDA to factor that into their decisions. Okay, so a little bit of an overview, and if you look at an org chart of the FDA, it's extremely large and extremely complicated. I'll just go over a couple of them. One is the Office of Patient Affairs, which is actually within the Office of the FDA Commissioner, and they schedule these interactions. We'll go over a couple. One is called a rare disease listening session. One is called a PFDD. So they're sort of the first point of contact for patients who want to talk to the FDA about their disease area. So the major regulatory agencies are CDER, which stands for Center for Drug Evaluation and Research. So that is concerned with sort of traditional small molecule drugs, as opposed to CBER, which is Center for Biologics Evaluation and Research, which regulates things like gene and cell therapies, as well as anything involving proteins. And then, so tonight, as our dinner guest, we'll have Peter Marks, who is the director of CBER, and have a conversation with him. So there's also, the FDA actually puts a lot of their stuff online. You can, watch recorded videos of a lot of their interactions, and there's a sign-up location to subscribe. Okay, so we'll go over a few different mechanisms that the FDA has to get input from patients. Okay, the first is, and this was sort of the first step that, the consortium of LGMD advocacy organizations did, was a rare disease patient listening session. Then there's a patient-focused drug development session, and those come in actually two flavors. One is externally led, meaning by an advocacy groups. So we had one, which Jen will talk about, involving 6 different subtypes of LGMDs. They can also be internally organized. So if there's some particular topic that FDA wants to hear something, get a broad cross-section of patients' experiences, they will organize that. They recently had one on, gene therapies in general. There's also the opportunity of patients to serve on advisory committees. I don't know if any of you, followed the advisory committee, which was making a recommendation to FDA on the DMD gene therapy, but one of the members of that committee was a patient living with DMD, and having someone who actually lives the experience was, very helpful and provided a very important opinion. There's also the opportunity to give public comments on various things, and the LGMD community has commented on a couple of recent things. One on the advisory committee on DMD, another on the recent FDA organized PFDD on gene therapies, as well as FDA periodically hosts different events and webinars. I've actually had the honor of participating in a couple of those. So I'll talk about the rare disease listening session that was held in 2020. In view of COVID, it was held remotely, which means that those of us living with disabilities didn't have to travel, which was kind of convenient. Now, the way that this is kind of an informal meeting, it only lasts 90 minutes, and we had 15 presentations from either patients or family members representing 12 different LGMD subtypes. And the way that the listening session is set up is just for patients to tell the FDA what's on their mind. So, challenges of living with the disease, and what each of these individuals would consider a meaningful treatment, what each of these individuals would consider an adequate level of safety. Now, the meeting is considered a private meeting by the FDA, but there is a written summary which is actually available on the Speak Foundation. So now I will turn this over to Jen, as she was involved in the patient-focused drug development that we recently had for LGMD. Can you?
Thank you, Brad, for getting us started. So I'm here to talk about patient-focused drug development meetings, or PFDDs. These are one formal way that patient communities can communicate with the FDA and share their perspectives on living with their conditions. So these have similar goals as the listening sessions, but they have a couple of important differences too. First, they're much longer. They're can be like 4 to 5 hours, and that gives you a lot of time to really delve into the details. They're open to the public, so that means that a lot of members of the patient community have the opportunity to contribute their voices and share their lived experiences. This even includes not just having a lot of speakers, but it means people can sometimes call in, submit written comments, or even participate in live surveys. Also, by being open to the public, it means that it's not just the FDA there, but actually other stakeholders too. So you'll have representatives from industry that are developing drugs for these diseases. Sometimes you'll have people that are involved with designing clinical trials. So there's lots of people that really benefit from hearing directly from patients. And you try to get all of those people together to participate in these PFDDs, or at least to listen in the PFDDs. And finally, these are recorded. So even if you can't join live, there's recordings that are available online for the PFDDs. And their summaries of the meetings are written up in what's called the Voice of the Patient report. And that's publicly available as well. So you can find these online on the FDA's website. And those reports, those are an enduring resource for the community. They're something that people can find not just today, but 1 or 2 years down the line or even later. So if there's a new company that comes into the space, it's really easy for them to right away have this resource available and start to consider the patient voice. Okay, so Brad mentioned that there's a couple of flavors of PFDDs. The first one I'm going to talk about are these internally organized PFDDs. And this is when the FDA identifies a need for them to hear from patients. And this could either be on a condition or it could be on a certain technology or something like that. So just about a year ago, there was a PFDD for gene therapies. And the LGMD community was really well represented. We had 4 members that gave oral presentations. And then also there was a joint written statement that was signed by many of the LGMD organizations that are in this room today, as well as the MDA. So as I mentioned, everything's available online. If you don't have that website written down, if you just Google FDA, PFDD, gene therapy, you should find it pretty easily. And in September of 2022, we had an externally led PFDD where 6 LGMD organizations worked together to approach the FDA and shared our intent to host a PFDD specifically on 6 subtypes of LGMD. So this included R1, R9, as well as all of the sarcoglycanopathies. So this is a really great collaboration. It was Coalition to Cure Calpain 3, the Kurt and Peter Foundation, the LGMD2D Foundation, Speak Foundation, Cure LGMD2I, and the McCall-Lockwood Laboratory for Muscular Dystrophy Research. And we are very grateful that we had support from Sarepta, AskBio, Edgewise, ML Biosolutions, and Vita. So this is a virtual event, and over 600 people joined the meeting live. It was just a phenomenal turnout. So we were so pleased, especially with ultra-rare diseases, to have that kind of turnout. Over 400 of those were either LGMD patients or their family members, but we had 27 FDA representatives joining. We had nearly 50 drug company representatives. So we really tried to get a lot of the stakeholders in the room together. I know a lot of the people in this room were part of that, so I really want to thank you on behalf of all the organizers. It would not have been so successful without you. So we're so pleased to be able to incorporate your perspectives and your lived experiences in our event. So we wrote up a report about it. It's called the Voice of the Patient report. And this is just to show you a couple of examples of what's in that report. So in addition to including summaries and many quotes from people that participated, we included some light data as well. So on the left, you just see this is the representation we had, which was actually really well distributed between the different subtypes. And on the right, this is just an example of the sort of thing we learned. So one of our live polling questions asked about what daily living activities do you need help from somebody to do? And we gave them some choices, and they could select all that applied. And here you'll see that the common answers were transportation, meal prep, household chores. So, these kind of things are probably not a surprise to anybody here, but it's really important that the FDA hears it and that they hear it directly from you. So nobody's guessing. They should be able to hear from you what it's like to live with this disease. So I just want to touch on some of the themes that emerged. Our morning sessions talked about symptoms and health effects of LGMDs and how they impact people. So we heard that LGMDs are progressive diseases, but that symptoms progress at different rates, and it's variable between people, but some people are really severely affected. For certain subtypes, multiple body systems are affected, and that also individuals with LGMDs often experience discrimination and social exclusion. I'll say one other topic that came up a lot was discussing independence, people's desires to maintain their independence and fears about losing it. In the afternoon, we talked about current approaches to managing LGMDs. Basically, there are no current treatments that change the course of disease, so there's a huge unmet need there. And we also heard from quite a few people that are eager to participate in clinical trials. So if you're interested in hearing more, it's all available online, lgmdpfdd.com. You can watch the recording, you could read the report. There's a hard copy of the report out on Speaks table right now, but it's all easy to get. So as Brad mentioned, there's other advocacy opportunities with the FDA. You can submit public comments to certain meetings and events that FDA holds. There's an opportunity to participate in webinars. And there are also FDA committees that will often want to include patients or family members of patients directly on that committee. So as he mentioned, the advisory committees, which make recommendations to the FDA about drug approvals. And then also the FDA has a patient engagement collaborative, and we have Carol Abraham, who many of you have met here this weekend, is on that committee. So if you're sitting here thinking that you have a lot that you want to tell the FDA, I'm sure you all do, there are opportunities going forward. So first, we did the ELPFDD with 6 subtypes, but we made sure that the FDA really understood that there are many more subtypes of LGMDs. So the FDA is open to holding other ELPFDDs for other subtypes in the future. There will be future FDA webinars and other events internally organized by the FDA, and also advisory committees that you can join. So how do you find out about these? You can go to the FDA's website. It is very, very dense, but if you search for the right things, you can find these opportunities. Many of the drugs that are in development are probably going to be just for one subtype at a time or just a few subtypes. So the FDA is going to be making decisions kind of on a subtype by subtype basis. So if there is an advocacy organization focused on your subtype, you'll really want to sign up to hear more from them or join their registry, and you'll get to hear about opportunities that way. And then finally, Speak Foundation has an advocacy initiative. If you are streaming this right now, there's an advocacy button, or you could go to Speak's website and click on the advocacy banner there. But they will keep you updated on opportunities. And as Paul mentioned, MDA also has advocacy opportunities, so you can look into that. So I'll hand it back to you, Sarah.
Thank you, Brad and Jen, and thank you to all our speakers for a fantastic session. Hopefully you have a really good sense of all that's been happening and what's coming up. And I just want to acknowledge that it can be a little bit overwhelming to hear about everything that's going on, but keeping the momentum going is one small way you can contribute and are contributing this weekend to advocacy, and that's through streaming or through being here in person and just being open to having these conversations. So thank you to everybody.